Hey guys, I'm Michael, and I'm going to be taking us through an initial assessment for an airway on this patient here. This patient is Steve. Now, for the arguments at the moment, if Steve was in fact conscious, I would make a bit of an airway assessment a bit differently to what we might do if we come across an unconscious patient. So if we get a conscious patient and Steve's sitting on a chair talking to us, we can assess the ability to take a deep breath whilst we're auscultating his lung sounds. We're going to assess the ability that he has to speak, whether he's speaking in full sentences, phrases, or words. Whilst he's doing this as well, we're going to be able to get a more global picture of his perfusion, his level of consciousness, and we can keep an eye on his respiratory rate as well. Moving on to the actual physical assessment of his airway. If he's talking to us, we can assume that it is patent, though if he is having a stridor or whistling with each breath, he may have a partial blockage. We'll need to make sure that we assess the airway, both the mouth and the nose, particularly in smaller children, for any foreign bodies that may be obstructing it. And we're also looking for signs of swelling or facial trauma, potentially burns if we look for singes and soot around the mouth and things like that. Now, if this patient, Steve, was unconscious, then we'd look to position him much like he is now, in this wonderful supine position. Assuming that he's not had any trauma recently, there's no need to keep manual inline stabilization. You can freely move his head around to get the best position to assess him. If Steve did have some sort of occlusion, then we'd use our trusty McGill's forceps to look further down into his airways to see if we can retrieve that using some McGill's forceps. Now, moving on to his breathing, like I said before, having a listen to his lung sounds, we're assessing for rise and fall of the chest. We want to look, listen, and feel during our primary survey, so that's looking in the airway for obstructions, like said. We're listening to hear if we can hear any breath coming out of his mouth, whilst also looking for rise and fall of his chest, with feeling breath onto the side of your cheek as well. If he is unconscious, it's probably not a bad idea to insert an airway adjunct at this stage, just to ensure you've got a bit more control over it as moving forward. Now, if Steve is unconscious, as we're going to move forward with this, we're now going to look at putting some extra airway adjuncts in, like I've just said. So, of course, we're going to size them up for an OPA, MPAs, and LMAs, but ultimately looking for a secure airway in an intubation, and we want to make sure that we can assess for any possibility of difficult airway and a difficult intubation. And to do that, we're going to use the LEMON acronym. That gives us a good idea of what kind of things we need to look out for in difficult airways. So starting with the L, you're looking externally, so we're looking for facial hair. Luckily, Steve doesn't have any hair. I don't think he's had some in a short while. Looking for large teeth or dentures or missing teeth. Steve hasn't had a little brush in a while, but he does have all the teeth and they look pretty anatomically normal size-wise. A short neck, or we're looking also for obesity. Hypo or hypothyroidism can cause a few issues as well. If the patient is pregnant as well, you may have a few difficulties moving forward with intubation, and it also adds a few extra considerations into your patient management. E, we're going to evaluate the 3-3-2 rule. So the ability to open the mouth, the width of 3 fingers at first. Now these mannequins don't have much compliance. I can just about get 2 fingers into this patient, so that's a sign of a potential difficult intubation. 3 fingers that will be able to place along the floor of the mouth, which is quite nice there, as you can see. It's quite good. And then 2 fingers that can be placed in the laryngeal prominence from the bottom of the chin down to the larynx. And if you can look head tilt, you can get 2 there. So we're going to have a little bit of difficulty with mouth opening, but for 3-3-2 rule, not too bad there. The M is the Mallampati classification. So what we're looking for here is it's a measure of the degree to which the tongue obstructs visualization of the glottis at the back of the mouth. The different classes. Class 4 is the tongue is quite large, or basically offers up a large amount of obstruction that you can't actually see any of the airway structures beyond it. Class 3, you can see soft palate of the mouth and the base of the uvula. Class 2, soft palate, the uvula, and you can start to get back down towards the fauces. Class 1, you've got the soft palate, the uvula, the fauces, and you can actually see the pillars at the tonsils down towards the back there. So having a look at this patient, he's a class 1. I can see quite comfortably down to the back. There's no issues with the tongue or the teeth or anything at the moment there. Now I'm just going to have a quick talk about how we're going to position Steve if we are going to be intubating him. So with Steve being unconscious, we want him supine, neutral position with a slight head elevation. So during the management, we can assume that he would hopefully have an OPA in at this stage and a bit of a head tilt as well, as long as there is no C-spine precautions necessary. When it does come to the actual intubation, to get the best view of the cords during laryngoscopy, we want the tragus of the ear to be in line with the sternal notch, which will probably be somewhere around here. Now, to maintain this, obviously you can't just leave your hand there, so luckily we have been provided with one I prepared earlier, which is a lovely bit of towel underneath the occiput of the head, and that's going to give us tragus of the ear to the sternal notch. There's a nice easy view of the cords during laryngoscopy. It's also known as the sniffing position, as trainees are told to position them as if they want to smell what's being made for breakfast. Now it's important to note that if this is a patient that has undergone some sort of trauma and you're wanting spinal precautions in situ, this is not to be used. There's too much manipulation of the C-spine. If Steve was a much larger man than he is, seeing as he doesn't have any arms and legs, he's quite small, but say he was a much larger obese patient, then ramping could be an option. That involves putting a lot of padding underneath the shoulders, really extending the neck down. It allows for a much nicer view. Now that will be necessary for Steve here. More often than not, you'll have to use pillows or a number of blankets to get a really nice view for that.